So hi, my name's Adriana and I'm part of Stigma Ends at CU, which is a campaign that functions out of Carleton. And we're doing a presentation here with Mark Barnes and my co-host Brittany.
Okay, so hi everyone, I'm Brittany and I'm one of the executives for Stigma Ends at CU, and I'm in charge of the external team with Adriana.
Hello everyone, my name is Mark Barnes. I'm a pharmacist and the owner of RespectRx Pharmacy. We are an inner city focused pharmacy that's dedicated to respectful approaches to substance misuse and complex mental health.
Perfect. And I'm just going to make you the host now, Mark, so you're able to share your screen and we can start the presentation.
Great.
You should be good to go now.
Great. All right, so with that, I will share my slides. Thank you so much.
No problem.
So, yeah, like I said, my name is Mark Barnes, pharmacist. So I'm actually thrilled to be here and to be invited part of this symposium today. And for many reasons, not limited to that, Carleton University has become a fantastic partner with me over the last couple of years. So much so that I'm proud to announce that we now have a RespectRx Pharmacy, Carleton University Perseverance Bursary. So we provide a bursary to one Carleton student every year. And really the criteria for me is not about academics or being a fantastic student. It's about sharing your experience. So basically realizing that you have battled through a complex mental health issue, or maybe you're still battling, or a substance misuse issue in the past, to be a successful student at Carleton, which means that you're going to school. Maybe you don't have the best marks, I don't know, but you're there, you're doing it, you're doing the work to get better every day. So that is something that we have created with Carleton University that we're very proud of. So that's how we're going to start off, just to show you the commitment I have to the student body there and how I value the partnership that you guys have with us. Now, I was a regular community pharmacist for many, many years, okay? The guy with the white coat on at a pharmacy that doesn't talk to you maybe when you walk in there. I was that guy for many, many years. During my time as a pharmacist in Westboro, so not too far from Carleton University, back in 2012, I dispensed a fentanyl pain patch, so an opioid fentanyl pain patch to a dying cancer patient. Okay, she's a middle-aged lady with stage 4 pancreatic cancer. She sold her patch to a 19-year-old, so a college-age student from Manotick, who chewed the patch, drank some alcohol, and died, okay, acutely. He was partying with his friends and his family and his older brothers. That was on a weekend. The following Tuesday, Ottawa Police Service came into my pharmacy to discuss this recent death that had just happened. I was absolutely devastated as a pharmacist. I felt mad. I felt sad that if this could happen to me as just a community pharmacist, then who really can we trust with these opioid medications? So it just so happens that we had an interview lined up with Steve Fisher from CBC in and around the opioid crisis, discussing at that point what the problem was, OxyContin, way back in 2012. So he was coming in to speak to us anyway on a Thursday. Our conversation that Thursday, just less than a week after I found out about the death, quickly turned to this recent death that had happened. And we got talking about fentanyl right away. And then being a loudmouth Newfoundlander, maybe, I don't know, thinking off the top of my head, I don't know, I shot my face off to Steve and said, listen, you cannot get a fentanyl pain patch from my pharmacy here in Westboro unless you return an intact used patch back to us. So Steve then repeated it and said, so essentially, Mark, you're going to do a patch for patch return program. I'm like, yes, we're doing it. Then I turned around to my staff and said, uh-oh, I just told CBC we're doing this. We have to do it, right? And that's how it started, really. I shot my face off to a reporter. We started it in Westboro right away. That night, Steve reported it on CBC News locally here in Ottawa. Then nationally, it got picked up nationally by CBC that evening. The funny thing is, that was a Thursday. By the following Monday, just after a week I had learned about this fentanyl death here locally in Ottawa, I had over 30 media requests from coast to coast, Vancouver to Newfoundland, to discuss this fentanyl patch pain return program because they were having fentanyl deaths similar in all jurisdictions across Canada. I had no idea it was even happening. We advanced then to 2014. A couple years later, that program is now Ontario law. Everybody in Ontario has to return fentanyl patches in every pharmacy, all 4,600 of them, okay? And it's been adopted by 3 other provinces in Canada. It's called Safeguarding the Community Act, Bill C-33, okay? Put into the House of Assembly through Vic Fideli, an MPP from North Bay. But I'm not here to talk about fentanyl patches or patch return. I'm here to talk about the opiate crisis and how to prevent one with naloxone. Because what happened at that time could have been prevented with naloxone. What we did then as professionals is we actually started to think about what we want to do professionally. And I knew that I wanted nobody else to die of a fentanyl overdose on my watch, is kind of what I thought, okay, at that time. So I said, let's start doing more and more substance misuse treatment and preventing overdoses and methadone, Suboxone, and OST, and all the other things are in and around substance misuse there in Westboro. Then we got really popular at it because we were different. We knew that the biggest thing missing from patients and dealing with substance misuse, complex mental health, was respect. Respect for the client, respect for their history, respect for the trauma that they've been through. That was the biggest thing missing. So we sold Westboro Pharmacy and we opened the first Respect RX pharmacy in Vanier. So we called it Respect so that not only is it kind of our name, my wife thought it was a silly name at the beginning, but it's our mission statement. Okay, and this is the truth. Now, when we first opened, it was between a beer store and a bar in Vanier. The absolute brutal spot to open in a wellness place for someone's substance misuse, okay? But no one would lease to us, which speaks to the stigma around addictions at that time. They didn't want our clients mixing with their clients. Made me very frustrated. That was the stigma around substance misuse back in 2013 when we opened the first one. Advance, now here's the big thing. When you show empathy, dignity, respect, compassion to somebody on their worst day, their absolute worst day, the day that they roll in on ground zero, I call it. They roll in from a crack house, completely addicted to opioids in acute withdrawal. Maybe they have just lost their employment from a substance misuse issue and are coming in for treatment. Maybe they have just experienced physical or sexual assault and they need shelter and caring compassion along with substance misuse treatment. Okay. But when you show empathy, dignity, compassion on somebody's worst day, not only do you gain a friend in that person forever because you were there for them on their worst day, they want you to help their whole community. So now, just advance a few years later, we have 5 Respect RX pharmacy locations. And now, not having 0 patients, we now have 3,000 patients who are battling substance misuse in our region every single day. And my story today about stigma, about compassion, empathy, and respect for substance misuse isn't my story, right? Kind of is at the beginning, but it's the stories and the voices of my patients that makes a big difference, right? And why we have to prevent opioid overdose in the first place, and why naloxone is so important for these people to stay alive. And that's the important thing. But I have to show this picture. Why? We're no longer between a beer store and a bar in Vanier, which is awesome. And this building is very special to us because this is the place that we wanted to lease when we started looking for a spot in Vanier in our first location. And the owner of this building at that time, who is a health professional, he was a physiotherapist, was the one that said, I don't want my patients mixing with your patients, right? So advance a few years later, we now own the building. Okay, so we've moved on, moved upward, but also this allows me the opportunity to show you that it's not just Respect RX Pharmacy and pharmacists doing this work, but we have many partners in our community that work alongside with us and co-locate with us. The owners of Recovery Care, which is Donna Sarrazin and her team, are wonderful individuals that actually have the same like-minded respect-based approach that we have. That's the physician side. So that's the physician office clinic, walk-in service, Monday to Friday, 8 to 4, to get treated for opioid use disorder or other substance misuse issues or complex mental health. Okay, really awesome. So we have professionals from Recovery Care. We have professionals from Respect RX. 2 pillars of healthcare. Still not enough. It is not enough to break down the barriers of substance misuse and complex mental health, the stigma around it. We need it more. We need more of a holistic approach to wrap around people to make them well. Maybe it's a free ride to treatment. Maybe it's free seminars at Carleton like this. Maybe it's I don't know. I can give you a whole bunch of things we need to do. So we developed a a third organization called Pathways to Recovery, which is a nonprofit organization where professionals from both recovery care and RespectRx come together to make decisions about holistic care in our community. And ran by Recovery Care and Inner City Health, there's a brand new outreach treatment van that's coming, like a mobile health unit that's going to go out to some of our troubled neighborhoods to help provide support with substance misuse and complex mental health, right? So there's a van that's actually on the road. It's going to start next week. It's pretty exciting. So that's kind of some of the work that we're doing, who we are. Now you know who I am. So that's good. So you can get a perspective about what I'm about to tell you. The task at hand today is opioids. So important. Okay. Now I'm going to speak on both sides of my mouth today because I have to, but really opioids are not bad medications. They're not. As a pharmacist first and a treatment professional, they're not bad, but they should be reserved for advanced cancer pain, advanced acute pain, like ripping your wisdom teeth out of your gums, okay, because it hurts, and or to put you to sleep for surgery. Now let's keep that in the back of our minds as we discuss the opioid crisis. Now, common names out there that you'll see prescription side of things like hydromorphone, morphine, codeine, OxyContin, Percocet, Tramadol, Tramazet. These are all opioids. And I will mention here lean, especially when we discuss stigma and Carleton University and this age group in general. Lean is codeine cough syrup or Vicodin cough syrup. So two powerful cough medicines that are prescription opioids, but then they take them from the pharmacies. They're brought to the street, mixed with alcohol like vodka and rum, fruit juice, Sprite, or 7-Up, whatever, and then market it to youth and college-age kids as just an alcoholic beverage. But it's not. It's an opioid. Very common now in Eastern Ontario. Very common in Canada. During actually COVID-19, there was a very organized forgery ring in Ottawa of people trying to access codeine cough syrup and Vicodin cough syrup from pharmacies to make lean from fake prescriptions passed through Apple Tree Medical Centers. Very organized, actually. So lean is very prevalent. Even my own 16-year-old daughter, who's been at parties recently in our region, has seen lean. She says it's market. She says, Dad, it's extremely common. Terrifying, but I want to mention it today. Now, if we go back a decade ago, back to 2012, during my problem back then, and I had to ask anybody out there, not just from a prescription source opioids, but on the street, what is the most famous and most popular street source bootleg drug den opioid out there? Everybody would have said it's heroin. Now, advance a decade later, 2022, where we sit today, heroin is gone. It is gone. It has been replaced with bootleg drug den, street sourced fentanyl. Why is this a big problem? Well, fentanyl is 100 times stronger than heroin per milligram strength. Big problem. And during COVID-19, drug dealers have a hard time making a consistent form of the fentanyl. So now there's hundreds of analogs of fentanyl out there in our streets. Some of them are as strong as carfentanil, which is 100 times stronger than fentanyl. So in essence, what I'm trying to say is that just in a decade, 2012 really to 2022, the toxic street drug supply in Canada and most regions, especially here in Ottawa, is now 10,000 times stronger than heroin per milligram strength. Tragic. So not only do we have an opioid crisis that's happening and people consuming opioids at large amounts, larger than we've ever seen, we have a non-opioid street drug issue where we're finding minute amounts of these very toxic opioids in all other street drugs. Molly, ecstasy, crystal meth, speed, crack, you name it, even street source cannabis can contain opioids. So our public health unit, I sit on the Overdose Task Force in Public Health in Ottawa. We put these cards out that says anything can be cut with fentanyl or carfentanil, meaning anything can be mixed with these opioids. So even kids who didn't want to take an opioid in the first place are still overdosing. I tell youth and college-age kids all the time, the same message. Assume all your drugs have opioids in them. Carry naloxone, never use alone. That's the message, okay? Now, what is an overdose? What's actually happening to the body at that time? And really, you got to think of it as going to sleep for surgery. The doctor says, okay, Brittany, it's time for your knee replacement. I don't know. Count backwards from 10. 9, 8, 7. You're unconscious, okay? Just like every episode of Grey's Anatomy, okay? You go unconscious for surgery, okay? 9, 8, 7, you're out. As soon as you lose consciousness, the first thing that the doctor will do there is they will intubate and ventilate. They'll hook you up to a machine to keep you breathing. Because not only do opioids kill pain, sedate you for surgery, they acutely stop breathing. Okay? So on the street, what an opioid overdose is, you stop breathing. Simple. The brain becomes saturated with the opioid. Your breathing's suppressed immediately. Your brain becomes hypoxic, which means no oxygen, and you're dead. Now, how fast does that happen? 3 to 5 minutes. Most people are dying of an acute overdose situation right now. Paramedics might have been called. They could be en route, but they didn't have a tool to keep someone breathing until paramedics got there. And paramedics are overwhelmed. I have a bunch of friends that I play hockey with that are paramedics, and they tell me on average, they used to get an opioid call like once every 2 weeks. Now they're getting 2 per shift. Very prevalent, right? And that's troublesome. So that is what an overdose is. I really wish I could tell you, describe this slide to you and how it makes me feel, okay? You talk about stigma, you talk about where we are in the world, okay, in general. Put it this way, the Ontario government and the Canadian government lost their collective marbles, okay? They freaked out about the opioid crisis in Canada back in 2018, when this acute number of deaths reached 4,460. Now advanced to 2020, last full year of record that we have for data, we lost 6,214 Canadians, representing 1 Canadian every hour in like 15 minutes. Since 2016, we've lost well over 25,000 Canadians. Remember, we've only lost, I shouldn't say only, we've lost like 35,000 people from COVID. We will far exceed that number with opioid overdose deaths moving forward, right? It's an epidemic that's happening in the face of this pandemic, and no one's really talking about it, right? Why? Why is this? We're still spending billions on COVID. Not that I'm saying one is worse than the other, but we got to start looking at other social issues right now, start peeling off the blanket of COVID and seeing what else we got to fix. And this is one big problem we have to fix. We do have the data out of the first half of 2021. Not great. 3515, which means we're probably seeing in 2021, maybe 7,200 deaths in Canada. It's tragic. This is absolutely tragic. Now, we look at the trend in Ontario. It's a really good picture of kind of where society has gone around the opiate crisis. Remember my problem back in 2012 with the fentanyl patches in Westboro? Look at that number. It was only about 500 and something deaths then. I shouldn't say only. We still lost 500 people in Ontario. But since then, you'll see a sharp curve upwards towards 2018, 2019. This is the introduction of fentanyl to the streets of Ontario. And then you'll see we flatten the curve, okay, in 2018, 2019. Most provinces actually decreased. Ontario was only a slight increase. That is when Ontario activated the emergency response system around the opioid crisis. We put out naloxone and overdose prevention tools in droves. People had access to social services all over the place regarding the opioid crisis. Okay, we talked about it. There was public advertising, and it worked. We started, not necessarily got better, but at least we started to tread water and not increase at the same rate that we were. We started to just start to break even, get a handle on it a little bit. And then 2020 hit. And we lost 2,426 Ontario people that year, representing a 60% increase year over year due to COVID-19. Fear, anxiety, isolation, and actually access to cash and CERB led to more overdoses we've ever seen. And it is continuing to go on in 2021, 2022. And we'll probably be digging out of this mess for the next 5 to 10 years. This is the problem that we will have for us as we age over the next decade, trying to solve this opioid crisis problem. Now, no public health unit in Ontario is exempt either. We talked about paramedic service. This is another notice of the same kind of information. Out of the long weekend in July, they talked about opioid overdoses and breaking records. This is a notice out of Sudbury about a product marketed as THC Gold, just a cannabis product that contained carfentanil, and kids died. But we know we did the work before and it worked. We know we did the work in the past and it worked. We stopped the growth of the opioid crisis and even started to decrease in most regions. And we did this through naloxone and talking about the problem and not sweeping it underneath the rug. And it worked. The best region actually at that time for reducing overdose deaths with naloxone was Ottawa. We had 38.1 kits dispensed in our community per opioid harm, more than 4 times the average. It was amazing. Me and Vera Etches actually discussed this. It was awesome. We won awards for this. But I don't like to focus too much on how good we were, because that's not why I'm here. I actually focused necessarily on the lives saved, but lives that we lost, because I think we could do a better job. So during this time frame, we still lost 64 people in Ottawa. We put 64 pairs of shoes down on Parliament Hill to represent each death from the opiate crisis. At the Overdose Task Force, when I communicated and asked questions about the 64 deaths, maybe it should have been 250, I don't know, but we lost 64. So I asked the coroner's office, I'm like, hey, of those 64 deaths at that time frame, how often are we finding naloxone at the scene of a death? In other words, how often did the person even have a chance to make it? And they came back, Mark, and said, sadly, 1 in 4. I'm like, brutal. So if I was the best in Ontario, capped in naloxone, putting out 38.1 kits per harm, and I'm only batting 25% of the time, that got me thinking, how much more naloxone do we have to put out in our community for it to be effective? And the answer is, especially because of COVID decrease, a hell of a lot more than we're doing now. That's the answer. So then we had to start thinking about who needs it. Who needs naloxone? Who is at high risk of an opiate overdose? Okay, well, the Ontario government thought about it too. And we now have in 2022, new legislation coming out. We've been working on this for years, actually. I make it sound like it's easy, but we've been working on this for years in the construction sector. But they just announced, guys, not even a month ago, about workplaces that are going to have mandatory training and naloxone on site, or else they're subject to huge fines. Yay, finally they listened to me. I'm going to be one busy boy. I think I'm the only pharmacist in the world out there with work boots and a hard hat ready to go to construction sites to do training, because it's coming. I'm very busy this way. But if you look at medical literature long before this legislation, okay, if you look at medical literature, they said, who needs naloxone? Well, medical literature wants you to focus on 3 areas. Area number 1, people prescribed opioids. Oh, so it's not just a guy with a needle in his arm on the Lower East Side of Vancouver who's homeless. No, that's media propaganda. It's actually people prescribed opioids just like me and you. Okay? Why? 1 in 3 people who die of an opioid overdose in Ontario have an active prescription for an opioid at the time of death. And 1 in 2 of them, 50%, tried to access the medical system at the month of death. We're missing them. So 1 in 3 have an active prescription. So it's not just illicit use, it's also prescriptions, okay, that are getting on the streets. Now, here's the sad thing. We dispense, well, it's not really sad, sometimes we need them, but we dispense over 100 million opioid prescriptions per year. Okay? An opioid, we actually see about 100 million opioid prescriptions per year, more than 3 per person. Okay, that's tragic. Of those opioid prescriptions in Ontario, less than 1% receive a free naloxone kit. We must get them. Okay, the second group of people who need support, friends and family. Over 70% of all opioid use, all right, is also from people who didn't even prescribe them. It was their friends and family who got access to them. We're seeing this in our construction sector. 1/3 of those people are in the construction sector. And obviously you're a substance misuse patient as well. So important, okay? So important to deal with the people with a substance misuse issue. It's a relapsing condition. They must be supported. But we can't just stop here, because if a rich young white student rolls out of a mansion and says, I want to use a substance this Friday night because I do that once a month, and it's cocaine and it's laced with fentanyl, and she dies, she wasn't represented here. She wasn't prescribed an opioid, nor her friends and family, and she doesn't have a substance misuse issue, but she's still dead. So we also have to have a street perspective. And this is where the stigma has to go away around the opioid crisis. So important here, guys. Anybody who does not have tolerance to an opioid is at risk of an overdose. Whether it's a grandmother with her own prescription who hasn't taken it for a few days and then takes too much on Thursday and dies. You do not have tolerance to an opioid if you've never seen one in your body, or you haven't seen one in your body in a few days. The saddest story I've ever heard was during Frost Week this past year, and the University of Ottawa professor disclosed to me on a Zoom call just like this, that they had just lost their 9-month-old niece to an opiate overdose death because she crawled across the floor, got access to a tablet and swallowed it. Preventable with naloxone, right? Other medical problems, we have to protect people as well. People who can't breathe well, people who already have complex kidney and liver dysfunction potentially because they can't metabolize the opioid. Using alone, big problem, especially during COVID-19. We've asked people to self-isolate and stay away. The tool to keep you breathing is naloxone. It cannot be used in yourself. It's intended to be used in someone else. Those who carry naloxone should not be deemed or judged as drug users. They should be deemed people savers. And that's important. And then a previous overdose of any substance is a future indicator of more overdoses. And this is what everyone has a hard time with in our society. They don't understand how someone could use a substance, almost die, roll it on the street and use the same thing again. But I can't think of a better bullet point to describe to you what opioid use disorder is. People who are addicted to opioids, who can't stop taking them, it's not a character flaw. It is not a moral insufficiency. It is a true mental health disorder. People who choose to use opioids, they use them to kill physical pain because they're painkillers, but more often than not, greater than 70% of the time, they use them to kill mental pain. Okay, of all the drugs on the streets out there, opioids do the best job of turning off the brain of trauma. Okay, people who use the opioids at our centers describe them in 3 main terms. They say it makes them feel like liquid caramel. They say it makes them feel like there's a warm hug wrapped or a warm blanket wrapped around them. And the term used more often than not actually is that it gives them a warm hug. Wow, that's powerful literature to describe how it makes them feel. So if you experience trauma in your life and you're having flashbacks mentally of sexual assaults or abandonment or PTSD or a loss of a career or financial trouble or marital issues, and you have all these constant reminders flashing at you all the time, the best drug at turning off the brain from all that trauma are opioids. The problem is where the hug is the tightest is about 2 breaths per minute. The breathing's almost stopped. They are almost dead. That is the problem we're in. Okay. And that is why it's so important that we keep everyone alive and use naloxone to keep them breathing. So important. And the drugs, of course, are stronger than ever. Here's a picture of what it looks like. That's a 1-inch ruler on the right-hand side. There's 3 vials there. This is our toxic drug supply. People can't control what they're using anymore, right? It's fentanyl, carfentanil. It's the size of a few grains of salt can kill you, right? It gets accidentally mixed in anything and people are consuming it and not knowing what they're taking. So a part of this is knowing the signs and symptoms of opioid overdose so we can intervene and keep people breathing. So some of the signs and symptoms are put out in public health. They're all over the websites they'll show you, and they're on these black cards that you can get. The first one is a decreased level of consciousness. You can't be woken up even if a pinch or shake you. Then the pupils become pinpoint, which means the black part of your eye is almost non-existent. All you can see is the color part. If you have bright blue or green eyes, it's very distinctive. Then there's a deep snorting or gurgling sound. Same sound you make if I took my hands, placed them around your neck and choked you out, but there's no hands around your neck. Then the lips start to turn blue and the fingertips turn blue. Then the whole face turns blue and your whole body really. Blue is the color described by medical literature, but really only pertains to pale white people, okay? If you are a dark complexion, it's more of a gray color. So if you're indigenous, Middle Eastern descent, black, it's gray. And we are a multicultural society with a bunch of ethnicities. That's what makes Canada awesome. So we have to realize that it's blue is great for white people, but it's actually gray for everybody else who is not white. So blue or gray, we need to update our literature, and our cards are being updated, which is nice. And then vomiting happens, but it's not vomiting like you normally think. It's just white cottage cheese type foam around the mouth. And then the people start to shake. This is your signs and symptoms of overdose. Okay. But if I had to ask anybody last night who used naloxone, what did you see? They always say the same thing. Pinpoint pupils, gurgling, blue and gray lips, and shaking. That's what they say. If you know that, you're ready to intervene. You're ready to intervene with naloxone. Now I've teased you enough. What is this stuff I keep talking about? What is this compassionate, stigma-free medication to keep people breathing? Okay. What is it? It is like the EpiPen for opioids, but it's just a nasal spray. Super cool, actually, because like an EpiPen can't remove peanuts from the body, This doesn't remove the opioids. You're not peeing it out or pooping it out. You're not going to puke the opioid out, right? It doesn't work that way. What it does, you take the spray, it goes into the body where it needs to go, removes the opioid off those receptors in the brain and the spinal cord and the lung, allowing the body to breathe for a short time until paramedics get there. So now we have a tool to keep them breathing until paramedics get there. It only takes 2 to 4 minutes to start working, and the person doesn't even have to be breathing for it to work. Phenomenal stuff. They don't even have to be breathing for it to work. Super low invasive. Love it. Love this stuff. Now, some people are afraid to use it. I'm not gonna lie to you. There's a lot of stigma out there around withdrawal. Everyone's like, oh, Mark, I can't use naloxone on someone. They'll wake up and they'll be in acute withdrawal. First of all, if it's an accidental ingestion, there's no tolerance. There's no tolerance, there's no withdrawal. Second of all, they have taken enough opioids to kill a horse. Remember, stuff is 10,000 times stronger than heroin. They have taken an overdose, not just enough dose. So the chance of you causing acute withdrawal is almost zero now, right? Most people require several sprays sometimes to wake up. Now, will they wake up with agitation and anxiety? Yes. That is not withdrawal, media people. That is a normal human response. Think about it. You're at a party, okay? You're at a party and someone gives you a drink. You take a sip of the drink and you wake up 7 minutes later with some guy pushing on your chest, something shoved up your nose, your friends and family standing around you crying, and sirens in the background. Are you going to wake up, best party ever, or are you going to wake up with agitation and anxiety? The answer is you were not expecting to pass out. The answer is agitation and anxiety. That's a normal human response, not withdrawal. There's a lot of stigma around withdrawal. It's not real, okay? Now, we have to respect those with lived experience who have tolerance, that they're afraid of withdrawal, certainly, but the chance of you causing with one nasal spray is very low now. And it only lasts, remember, the duration of effect in naloxone only lasts 20 to 40 minutes. The person will slip back into overdose. It is a medical emergency. We have to call 911. But don't be afraid about calling 911, because Narcan nasal spray is the safest thing that I can dispense in a day as a pharmacist. It is actually safer than Advil or Tylenol. I can Narcan each of you right now and nobody would feel a thing. I have Narcan myself in front of my kids actually to show them that it's inert. It does nothing. Now my wife called me an idiot, okay? But I did it. I want them to see it, to show them that it was inert. It's completely safe, right? It will have no effect on someone who hasn't taken an opioid. So even if the shaking was a seizure and you got it wrong, it doesn't matter. Even if the blue lips was a heart attack and you got it wrong, it doesn't matter. It's safe. I feel like Oprah Winfrey. You get a spray, you get a spray. Walk into a party, I told my daughter, and just spray everyone. I'm just kidding, don't do that, but you almost could, because it's that safe, right? Now, and what is really cool and what kids need to know, what society needs to know, is that our Good Samaritan Drug Overdose Act supports the use of naloxone. It says that no one's in trouble for using Narcan, even if you were wrong. And even if you're using opioids yourself, you can't get in trouble from the police. Our police are really starting to reduce stigma around opiate overdose, around addiction and complex mental health anyway. There's a big movement from the Chief of Police of Ontario and rest of Canada to decriminalize all simple possession of substances. Maybe they're starting to realize that putting people in jail doesn't work. Putting them in treatment works. That's the difference, right? There you go. That's what they're thinking. So that's great. So no one's in trouble. Look it up, the Good Samaritan Drug Overdose Act. It's awesome. Now, how do we use it? How do we use Narcan nasal spray? Normally we'd be all together and we could be spraying each other. Okay, we can't do that right now, but I will bring it to my website, naloxonecare.com. She's got it right in front of her. That a girl, perfect. Okay, we're gonna do naloxonecare.com. Gonna bring it to it. It's a training video, okay, of how to use it. So everyone at Carleton can do this. They can go online, go to naloxonecare.com, click on order a kit, and watch the training video. So here it is. I'll show you guys now how to use Narcan nasal spray. I'm going to share my screen again, this time with sound for video clips, so you guys can watch the video, and we'll reconvene after.
In 2018, 1 Canadian died every 2 hours from an opiate overdose, and this number continues to rise. It's not just heroin or fentanyl users in the streets. It's grandmothers with their own prescriptions and kids who didn't even know they took an opioid. My name is Mark Barnes. I'm a pharmacist and the owner of NaloxoneCare.com, an interactive website designed to allow more Canadians access to life-saving drug Naloxone. Naloxone is the drug that's found in an easy-to-use Narcan nasal spray. It can reverse the effects of an opiate overdose in as quick as 2 to 3 minutes. After you complete a simple training and answer a few questions on this website, we can send you a Narcan nasal spray kit directly to your home. So what are opioids? They are painkillers such as codeine, morphine, OxyContin, Percocet, and fentanyl. Recently, much stronger powdered fentanyl and carfentanil are leading to accidental use and overdose because they are so small and hard to detect if mixed with other drugs. With this Narcan nasal spray antidote, you can deliver 2 milligrams of naloxone directly to the bloodstream. Although naloxone can reverse the effect of an opioid overdose, it cannot remove the opioids from the body. It's important to call 911 after you administer the spray because in 20 to 40 minutes, the effects of naloxone will wear off and the person will slip back into overdose. The time it takes when an opioid is ingested to overdosing and death can be as quick as 3 to 5 minutes, which is why it's so important to recognize the symptoms quickly. Here are the 4 major symptoms of an overdose. Unconsciousness. The person is not moving and cannot be woken up, even if you shake or pinch them. Pinpoint pupils. The person's pupils are small and hard to detect. Snorting or gurgling sounds. The person can be heard gurgling or choking, and breathing is shallow or undetectable. Blue and gray lips. The person's lips turns blue or gray. Other symptoms include cold, clammy skin, foaming at the mouth, and shaking. Every naloxone kit you order from naloxonecare.com includes a case, latex-free vinyl gloves, a CPR mask, 2 doses of Narcan nasal spray, an identification card letting everyone know that you've been trained to use naloxone, and instructions. We like the 5-step approach to respond to an opiate overdose. Step 1, shake and shout. Assess the person and remember the major symptoms of an overdose. Step 2, call 911. If the person is unresponsive, call 911 right away. Step 3, administer the naloxone. Lay the person on their back. Remove the device from the packaging. There's only 1 dose per device, which is ready to use, so do not test or prime the device. Tilt the person's head back and provide support under their neck with your hand. Gently insert the tip of the nozzle into the nostril. Your fingers should be right up against the nose. If giving to a child, make sure the nozzle seals the nostril. Press the plunger firmly with your thumb to give the dose. Remove the device in the nostril. Step 4, chest compressions. Start CPR as it takes 2 to 3 minutes for naloxone to start working. If you have an AED, use it. If not, push on the center of the chest. This pushes any of the oxygen left in the body to the brain and circulates naloxone to the areas of the brain and lung to start working. Step 5, is it working? If you do not hear a deep breath in 2 to 3 minutes, then go back to step 3 and administer a 2nd dose of Narcan nasal spray found in your kit. Once the naloxone is actively working and the person is breathing on their own, put them in the recovery position. The recovery position helps open the person's airways and avoids choking on vomit or spit. Remember, naloxone only lasts 20 to 40 minutes, so an overdose can return. It's important to get the proper medical treatment. Tell paramedics everything you know about the situation so they can provide the best care. Get trained, get a kit, save a life.
Okay, so that's the end of the video. So that's how we use Narcan nasal spray. I could already be convinced to change it, how to use it, because talk about stigma. They study the effectiveness of naloxone in mortality and morbidity data. Hey, did you make it? Did you not make it? Very, very disrespectful for somebody who needs this to live every day as they battle their substance misuse issues, right? And that's the thing. So I'm seeing a consequence of people who use naloxone have had lack of oxygen to the brain for a little while and are delayed after, or have permanent medical damage every time. After every overdose, it gets more and more delayed. And people overdose sometimes 6 times a month, right? So we need to get Narcan in the body as fast as possible. So my new, faster, sleeker Naloxone 2.0 video, I guess, will be like this. Step 1, 2, and 3 are very fast. Step 1, your assessment. We don't care, remember, because it's safe. Narcan them anyway, even if you're wrong. But pinpoint pupils, gurgling, blue-gray lips, shaking. That's it. Step 2 is to call 911. But now someone's calling 911 for you. Or maybe put them on speakerphone, because we all got cell phones. We all know how to use them. Put them on speakerphone. That way you have a timer going as well. But also, you're not waiting for 911 to tell you what to do, because you are a Narcan superhero. You are going to grab your naloxone, you are going to whip it open, and you're going to spray it. It's simple. I'm trying to make it sound exciting, but it is just a nasal spray. Here it is here. Okay, the red plunger is what you push, but when you hold the nasal spray, you hold it like that in your fingers. You place it in the nostril up to your fingers. You twist towards the eye, left nostril, left eye, right nostril, right eye, and you spray it. There you go. Live action shot. Boom. I just shot it 2.5 feet, 3 feet in the air. But what I wanted to show you is that the plunger's gone now. It's a single-use device, already primed, ready to go. You've delivered it. Now is not the time to like Instagram or like what do you guys do? TikTok, all this cool stuff, Visco video of yourself being a superhero. I don't know. It's not the time. Now's the time you do CPR right away, right? If you have an AED, use it. But you push at the center of the chest for about 2 minutes, 120 times. And then when it kicks in, you'll hear a sound that's heard in every reversal. You'll hear this, a deep breath. If you don't hear a deep breath in about 2 minutes-ish, remember you got your cell phone going with the timer on it, then you grab another spray and you do it again. And it goes spray, chest compression, spray, chest compression, spray. And you keep going, okay, until you run on the naloxone. The paramedic or the security Carlton U tells you to stop, or the guy takes a deep breath and is breathing better. Now, step 6, which is not in the video, which I will add, is your own personal wellness check. You've been through something traumatic, especially a loved one or a friend. Like, it freaks you out. They almost died in front of you. It's actually very stigmatized or very traumatic, actually. Okay. And it's okay. And maybe something even in this whole presentation has made you feel unwell, or you found some of the information triggering or upsetting. Well, I know Carleton University has a fantastic resources for everybody. Okay, I'm going to share my screen again just for a second to show you guys. Carleton University has a bunch of resources. You guys know it, a lot of people do, about what's actually available for you guys, which is wonderful. I'll go back to this in a second, but at Carleton University, you guys have a bunch of health and counseling services available, and that's important to note. If you go to the website, Carleton University, obviously, and check their counseling services, there is a ton. There's an extensive list of online phone, other medias as well. And you're not only just doing stuff alone, you also have support of CAPSA, which is an organization, that a Community Addictions Peer Support Association. Okay, they have staff Zoom meetings. These meetings are about to change. They're going live again soon too, I know that. And also you have a whole bunch of other Carleton University resources in and around other things outside of substance misuse, right? You guys are by far the most inclusive, wonderful organization that I've had the pleasure to deal with, that's for sure. From your president down, who's actually disclosed publicly his own battle with complex mental health and substance misuse in the past, which is a very powerful message that we can all learn from. And of course, they also have peer support groups in Ottawa. Okay, I will mention Recovery Care is there as a resource, and I did cheat. I put it in bold. Okay, I did cheat. They're partners of ours, so I'm very, very proud to actually put them in bold that they are open for service as well, recovery.care. Now, I want to go back just to show you one more thing, and then I'll stop talking because I know I could be here all day. Okay, there's my website. Okay, right there. Getting naloxone in Ontario, you don't necessarily have to go to a pharmacy, but though you can, there is a pharmacy community program, right? You can go to a lot of pharmacies doing great work, but remember, less than 1% of opioid prescriptions receive naloxone. So a bunch of pharmacists say they're doing it, don't really have the resources. I am working on my profession, but our profession, embarrassingly enough, has a lot of shame and stigma around substance misuse, right? We are the gatekeepers of opioids. Sometimes we are judgmental about naloxone, and we deem people to be drug users if they ask for naloxone rather than people savers. But I am really working hard every day to change our profession. I developed a guideline that is being distributed through associations and conferences, but you can bypass all that and go to naloxonecare.com and ask for a kit. Click on order a kit, and we can get that going for you guys. Now, the last thing I have to share, because it's almost my moral duty, I mentioned using alone as a risk factor for opiate overdose, and it was a big problem during COVID. Now there's NORS, which is a National Overdose Response Service. It's a phone number that if you have to use a substance by yourself, you can actually phone this number and they'll stay on the phone with you while you use the substance. And if you don't respond back or you're having trouble, they'll send EMS to your door. Pretty cool. It's a national service and it's free. All right. Okay. We talked about your resources at Carleton, which are wonderful. The last thing I want to say before I end any presentation is ask not why the addiction, but why the pain. So I'll stop talking and turn it over to see if there's any questions.
Perfect. Thank you so much. I believe Brittany had one question that we discussed earlier in the document. And then as we go through that, I'll just keep looking to see if there's any more.
Beautiful. Brittany.
Okay, yeah, I did have one question, but first of all, thank you so much, Mark. We're really honored that you came and spoke with us today, and your presentations are always amazing. So one question that we did have is, you've mentioned how you've made a lot of contributions to overdose policy development, things like that. So we're wondering how do you think policy should continue to change, or what would you like to see changed or implemented in the future to keep progressing?
Okay, so in and around the opiate crisis, there's a couple things. Naloxone, publicly funded and publicly accessible naloxone. Carleton's already superseded that. They've done that for me. They are big cheaters. They already won. They actually naloxone boxes on campuses next to AEDs, which is amazing, right? There's an example, but just talking about substance misuse in the general. So the policy's got to change from less of a criminality in and around drug use itself, but more of an open-minded treatment. I mean, if you really look at Recovery Kentucky, they did a lot of work in this whole field. So maybe it comes from lived experience. I don't know. But the governor of Kentucky way back when had some lived experience to his son, I think, who died of an overdose. So he took $500 million from the justice budget, so jails, and said, that is it. Now, if you get charged with a drug crime, you don't go to jail. You go to treatment, but the treatment is different. There's no, hey, you're allowed out in 2 weeks, you're allowed out in 4 weeks. No. You have to check a bunch of boxes before you're released. And it is, and you are educated. You have lawful employment coming up, whether it's a trade or whatever, it doesn't matter what it is. You've answered the bell legally to all your problems. You have social supports and you've reconnected with your family. All your debts to society have been paid that way. And then once you then are a fully functional, maybe able to better support yourself, that you don't have to turn to the substance again, then you're allowed to go on your merry way. It was so successful that the second time around, he was able to take another $500 million from the justice budget because the jails weren't full with petty drug crime anymore. People were getting well, and the chance of reoffending was very low. It was amazing. So that's the kind of policy change we need to have here. How's that?
Awesome. Thank you. I had one more question about the patch for patch program, or the patch and return patch program. What are the kind of outcomes you saw from that?
Terrible at the beginning. I'm embarrassed to say, okay, I'll tell you why. I did it at the beginning because back then I thought, arrogant young pharmacist, maybe, I don't know. Back then I thought the only way to control this opioid crisis is to control the supply of opioids. Right? Because, if I can't trust a dying cancer patient, then who can you trust, right? And that's what I kind of initially thought. But I think more often, and I quickly realized that I can never control the supply as Mark Barnes pharmacist. But with me, it was an awareness campaign around the dangers of fentanyl in general. But we proved through North Bay that it worked. So Tom Robinson, North Bay Police Force, all the pharmacists up there, all the police up there, everyone bought in, and they drove the price of a fentanyl patch on the street from $100 to $700. So we knew it worked. We knew it could help with just the patch part of it. But through my own MAKE evolution, MAKE, which is Martin, Adam, and Chris, 3 patients that I got to know about substance misuse, they changed me forever, realizing that we can't judge people who use fentanyl itself, because it didn't work in Ottawa. The fentanyl patch program didn't work. No one wanted to do it, right? Rather than controlling the supply, now I think if someone came in and they didn't return a patch properly, and I'm like, oh, you're misusing the patches, right? What am I supposed to do? I think I'd give them another patch. Complete opposite, because I think now, in theory, is because now I'm going to have a conversation about substance misuse, saying, how can I support you? Don't use the street fentanyl trash that's out there. At least I know what's in this. Be careful. Here's naloxone. See you tomorrow. Let's have another conversation about this. And eventually I will maybe stimulate change in that person over time through trust. So there's the difference. I think why I think the policy is not working or didn't work, but it was a springboard for us to have a bigger picture, a bigger look at substance misuse in general, and to understand it has nothing to do with the substance, right, at all. It's or the supply of the substance. It's about the mental health behind it, which I learned through my patients, right?
I feel like that program was a good way to introduce maybe someone like having a conversation with you, like you said, about substance misuse, because before a lot of people are very afraid to kind of come up with that kind of stuff. So maybe it was good in that sense that it opened up.
It was a gateway conversation back then, but now our gateway conversation, as I call it, is naloxone, because I take the blame out of the person and put it into a device that we can save people with. So now my big gateway conversation is around naloxone, and that everybody who gets an opioid prescription needs naloxone, right? Every single person. So then I just I normalize the conversation. I destigmatize the conversation by saying, everybody, I don't care who you are, if you're the chief of defense staff or you're a guy who's marginally housed rolling out of the Salvation Army, you guys all treated the same and you all get naloxone. So, it just normalizes the conversation around opioids in general.
Yeah, that's good. I've seen it at a lot of workplaces and stuff now.
It's coming. It's coming. Yeah, it's great.
Yeah, it's good stuff. Does anyone else have any questions or? Perfect.
I'll go. I just wanted to say, well, first of all, thank you for coming to speak to us. I'm actually just down the road from your original building and your new building, because I'm in an apartment building. I'm at Teres Gabriel on North River Road. Yeah. So I remember seeing you guys switch to the new building, and I was like, oh, yay, they got their new building.
Yes,
so I'm real close to you guys. And I was like, exactly. Yes, they finally got their upgrade. So like, yeah, I've been kind of rooting for you guys for a while, because like I take my pets to that, like to the veterinary.
Yeah, she's amazing too. Yeah, she actually, the vet there, she's lovely. And she also
she's awesome. She's great. She saves me so much money, like on stuff that's not necessary. So like that strip mall has like founded a bunch of awesome people in my mind. But like, so I'm pretty close to you guys. So hopefully I'll see your guys' new little program van going around with.
You'll see it. It's actually it's always be parked at 45 Montreal, our new place. It's going to be amazing. You'll see the van rolling around. It has recovery care on it. It has community health, it's partnership, and it's through some funding. Like I always say, well, Mark, what was the purpose of your nonprofit organization? I'm like, to milk money out of rich drug companies for our own philanthropy, right? Like, that's kind of what it is, because we take Gilead and other people who support Hep C medications are actually helping fund this thing with us to be able to, not me so much because I'm this Johnny pharmacist, but to get it out on the road with the real professionals that'll make a huge difference, social work and nursing, right? So
so like but yeah, I also just wanted to mention at the very beginning of your presentation and whatnot, you mentioned the increase in numbers, and you gave a statistic about how the increases of overdose deaths and whatnot has increased to about one person dies about every hour and 15 minutes.
Roughly. I think it's
and that number is actually, I have a very real perspective on the frequency of that, because that's about the frequency of deaths of veterans.
Wow, eh?
Yeah, so I have a very nuanced understanding of how often that number of deaths is. So like, I completely understand how horrible that must feel for you from your perspective as a pharmacist, and how much like you work in this field and how hard you're trying every day. So like I just want to say like how much I appreciate your work in this field and whatnot. And like I'm starting to get my start in my like education and stuff like that, and trying to find ways to do work with the advocacy and military families and whatnot, growing up as a military kid. So like I feel the pain, except, I haven't really been able to do much at my age. So like trying to figure that out. So like, I understand the nuance of that number specifically. So that really hit home, and it's hard to watch. It's hard to watch.
It's really hard to watch too. And, and you talk about breaking down stigma. One of the biggest parts I had back in the beginning when I was doing this stuff was the Anglican Diocese of Ottawa, a religious thing. And I mean, whether you're spiritual or not, it doesn't matter. But they felt that if they could carry naloxone and be trained as ministers, then anyone could, because they're a minister. But they are actually more than twice as likely to do a funeral for someone who dies of an opioid overdose than a car accident. Right? So there you go. That's another powerful statistic, right? To show that they can break down stigma around this, right? Like, it's crazy.
Grief is very interconnecting across many different spheres of
different
society.
ways. Yeah, you're right.
So it's astounding to me how many huge issues that people don't talk about. Like, despite like
Absolutely.
we talk about all the divides in society, but we don't talk about the interconnections. It's
Right.
always astounding to me.
Well, the group that I mentioned during your Carleton University Resources, CAPSA, has a fantastic way of presenting that. And their leader, Gord Gardner, who's awesome, talks about saying, you know, really, if you think about the population of Ottawa, there's 1 million people. He figures that 1 in 2, so 500,000 people have a direct connection or link to someone with a substance misuse issue. Right? So that's a lot. We're all connected.
Perfect. Thank you so much, Mark, for coming and presenting with us and stuff like that. I really appreciate everything that you brought in the naloxone. It was super informative, and hopefully everyone who watches the video or is watching it right now can go and check out his website and stuff like that and view the training and everything, because I think that's really important.
Please do. It's been my pleasure. Thank you very much. And